Attachment is relationally formed, either in its secure forms or insecure forms. The relational dynamics are fundamental to the creation of the attachment pattern. Then resolving attachment insecurity must also be relational. Okay? So a cognitive behavioral approach to resolving attachment insecurity will have some benefit, but I don't think that it will completely resolve or even significantly resolve the fundamental insecure patterns. But there is value in certain cognitive approaches as well.
David, welcome to the show.
Thank you. I'm really glad to be here. Appreciate this conversation we're about to have.
Now, I heard in another interview that you decided you wanted to become a psychologist at the age of 12. Um, can you maybe tell us about how you came to this realization and where this comes from?
Yeah, well, it had to do primarily with my sense of identifying with people that I observed as having some challenges, particularly insecurities, anxieties, worries. I was a pretty anxious young kid, and when I saw television shows that showed people with anxiety problems and insecurities and how they could be helped through psychotherapy by psychologists, by mental health professionals, I thought, oh, that sounds really good. I can relate to that. One of the early sitcoms that was really influential in this was the Bob Newhart show, where he played a psychologist, and the show showed him meeting with some of his patients or clients, and I liked what I saw. I felt reassured. I felt, oh, there's hope, there's possibility, there are people out there who would be interested in helping others, helping me. So I decided to be a psychologist, and that fits very well with what is commonly recognized within the field, the mental health field, um, of the notion of the wounded healer, that many mental health professionals can relate personally to the challenges that they help others deal with. So, yeah.
For sure, for sure. And you've been on an incredible trajectory since then. In addition to, I think you graduated from Harvard, you have developed a very unique approach to uh, treating attachment as well. And you've done some really interesting research in this area too. But I wanted to ask you, why dedicate your life or your working life to studying, researching, and treating attachment? Why is this so important? Like, why is this such a central thing for you?
Yeah, great question. Yeah, well, it certainly relates to what we were just talking about in terms of my personal history of insecurity, basically having a form of anxious preoccupation or anxious preoccupied attachment as a kid. So I know from the inside what this is like and what some of the challenges a child and developing person can experience as a result. But I didn't initially orient toward focusing on attachment. That came actually much later in my life and in my work, back in the early 2000s, I guess, when I took some training with Daniel Brown, who was a brilliant psychologist, a brilliant and creative, integrative thinker and practitioner, who through offered in his wonderful educational forums topics that were quite relevant to mental health and mental health professionals and their work. And one of those was attachment insecurity in adults. So I took some training with him, got very interested in that, connected with him and with several others who were also interested in training deeper on this matter and this topic with him. So there were 11 of us that decided to meet in an ongoing way, a couple times a month, to explore deeper the whole notion of attachment and particularly how to help resolve attachment insecurity in adults. So it was through that and through the collegial aspect, the relational aspect of shared exploration and interest that really built, cemented, and built within me more fully my passion for this.
Fantastic. So not only did you have a great mentor in Dan, you also had this group of 11 people that would meet up twice a month and really get to sort of share ideas and collaborate. And there must have been a great energy around that time as well, I'm imagining.
Very much so. Yeah, yeah. With our shared interests and you know, when you think about a collaborative exploration like that, it you know, it brings some wonderful connecting experiences, and it also brings challenges because we didn't always agree on everything, right? Those disagreements actually, you know, were part of the creative foment and what led to, you know, deeper understanding and new ideas of trying to resolve the differences that some of us were presenting. And I think that that was really fruitful in terms of the process of that group.
It makes a lot of sense. When you think even about like people competing in sports or anything, like having others around them that are at a high level that they can sort of push their weight against and bounce ideas off, and that's going to bring out the best in them, and the same in this kind of field as well. Like just to be in that kind of environment must have been so good for your development. So uh, another thing I've heard you mention, David, is that, and maybe I'm getting the stat wrong, but it was around 40% of the the population in the Western world are insecurely attached. First of all, is that right? And the second part of the question is, should we be aiming to create secure attachment, sort of make so that would be the almost like the default attachment pattern within society? What are your thoughts on that?
Yeah, well, that statistic that you cited is accurate based on the research that's been done, and there's variation across cultures and countries, but the general understanding from the research that is available about prevalence of attachment insecurity in adults is that about 40% within Western countries, particularly, let's say, the USA and in Western Europe, about 40% of adults have, um, depending on the criteria used, of course, can be considered to have some form of insecure attachment. And criteria differ, so there's different ways of identifying and categorizing, but I think that is a fair and fairly shocking statistic as well.
For sure. Have there been any studies comparing this with hunter-gatherer populations?
Gee, that I am not aware of. That's an interesting question, but I don't know of that.
Yeah, it would be interesting to understand, if cultural drivers of insecure attachment, as a like, are we, you know, are we wired to be secure, like predominantly, with insecurity being like an anomaly, or is it like should that ratio be around the 60-40 mark? I, I don't know.
I think we are wired to be secure. John Bowlby back in the starting back in the 50s or even earlier, he highlighted the evolutionary aspect of this, the survival aspect of the attachment behavioral system in infants. That from the earliest days after birth or even hours, there are there are innate behaviors that tend to try to capture support the infant, capturing the attention of the caregiver, to try to get the caregiver to be closer to have greater proximity to the infant, and thereby hopefully be able to attend to the infant's needs, which are basically survival needs during the earliest days and weeks and months of life. Now, attachment is a dyadic phenomenon. It's not only something in the infant. Ideally, something within the caregiver gets activated as well by the infant smiling, the infant crying, the infant reaching. Something in the caregiver, the reasonably available, the good enough caregiver, will pay attention to those signals and will come closer to the infant and try to provide for whatever the infant is needing at that time, whether it's food, physical contact for comfort and reassurance, whether it's stimulation so that the sensory systems will develop further. It's a dyadic dance that develops, and ideally in a good enough way so that developmental processes within the infant are supported and the relational dynamic between the infant and caregiver is strengthened so that that bond can support development over the next years of the infant coming into childhood and adolescence and ultimately adulthood.
Wow. Okay. What, I don't know if you've thought about this or not, but what kind of difference would it make in our world if tomorrow, by some magical miracle, everyone woke up and the whole world was securely attached? What kind of difference would society, or how would society look if everybody was securely attached? Like, what kind of effect would that have?
Wow, what a scenario. Yeah, what a fantasy. That would be wonderful, I would say. First of all, it would the amount of conflict in the world would diminish. It wouldn't go away. And as I think some degree of conflict is actually important. It's part of a creative developmental process. It's part of the birthing of new ideas and possibilities when there are certain forms of conflict. But the more toxic and noxious forms of conflict that, of course, take place or take the form of battles and wars and violence that harms people on small and large scales, I think that would significantly diminish. There's some very interesting research that highlights that people with insecure attachment, in contrast to adults with insecure attachment, in contrast to adults with secure attachment, um, tend to be more dogmatic in their thinking. They tend to stereotype others more. They tend to be more resistant to change their opinions about things when they're presented with evidence that is contrary to their opinions. Okay. So if you think about those characteristics and how prevalent they are in our world now, unfortunately, um, those things would diminish. So there'd be less stereotyping. There would be more flexibility cognitively, mentally, in terms of opinions. People would be more willing to change their minds when they're presented with new information rather than disputing the information because it conflicts with their beliefs. So yeah, this would be a good thing if this happened tomorrow morning. Let's see if it does.
That's huge because so many of the world's problems are caused by, you know, say some kind of charismatic leader with some ideology that he just, promotes. And then people that are insecurely attached because they're more vulnerable and more susceptible to dogma, as you're saying, then they blindly follow that authority. But whereas if they were securely attached, they have more cognitive flexibility and they can think for themselves and they're less likely to fall into that trap, So that's so, so important. Um, now, another question I wanted to ask you, David, was about you have developed this very unique model. I think it's called the integrative attachment therapy approach. And I wanted to ask what's the unique contribution you feel that this can make to our understanding and treatment of attachment issues?
Yeah, well, thank you. Yeah, that's we're my colleagues and I who've developed this integrative attachment therapy model are quite excited about it. We think it really does offer a contribution to the field. And I want to highlight just once again the contribution of Dan Brown, who died about 2 years ago, April of 2022. And he was really the innovator of a lot of the basic foundational ideas of what we were calling then the three pillars model of attachment repair and what we're now calling the integrative attachment therapy model. Integrative attachment therapy is essentially the application of the three pillars framework to treating adult attachment insecurity through psychotherapy. So that's the connection to these different terms. We feel that IAT, Integrative Attachment Therapy, builds upon what's developed within the field that has been really useful, the field of psychotherapy for attachment insecurity. And that field, the traditional model for therapy, is what I like to call the therapist as good attachment figure model, TAGAF, TAGAF. And this also was originated with some of the ideas of John Bowlby, who highlighted that he and others, particularly Mary Ainsworth, one of his close colleagues, and others who followed them, that because attachment is relationally formed, either in its secure forms or insecure forms, the relational dynamics are fundamental to the creation of the attachment pattern. Then resolving attachment insecurity must also be relational. Okay? So a cognitive behavioral approach to resolving attachment insecurity will have some benefit, but I don't think that it will completely resolve or even significantly resolve the fundamental insecure patterns. But there is value in certain cognitive approaches as well. So the IAT model uses 3 pillars. Pillars meaning essential components that are integrated and interwoven through a therapeutic process. The first pillar is what we call the enhancement of collaborative skill, collaborative ability. That's fundamentally the relational component to this model. And again, this gets to Bowlby's and Ainsworth's notion and also the TAGAF model. The relational component of the therapy is very, very important. This also comes from the psychotherapy research, which consistently highlights that the factor that is most predictive of psychotherapy outcome, regardless of therapeutic approach, is the therapy relationship, how the patient or the client experiences the therapy relationship. So in various ways, we highlight that as the foundation for IAT. First pillar, the collaborative enhancement. All good therapy is collaborative, even if it's not named to be that. It's a relational pattern where one person, the client, comes for help from another person, the therapist, but both have important roles to play. Neither can replace what the other is doing, and both collaboratively they establish goals and figure out the ways to work on those goals, hopefully successfully. So the second pillar is this relates to perhaps the cognitive domain that I referred to just a moment ago, but it's very specific. We call it the enhancement of metacognition or metacognitive abilities. Essentially, that's perspective taking. It's the ability to recognize that what's in my mind is in my mind, that something is going on in your mind, in your experience, that might be different than mine, or it might be similar. And also that certain inner states might be affecting my behavior. So if I am hungry, I might be a little more irritable, and you might experience me as being irritable toward you, and you might think, oh, he doesn't like me. But in fact, that would be your interpretation. You would be mentalizing about why I'm being irritable. But in fact, it's not that I don't dislike you. I mean, I like you very much, but I'm hungry, and so I'm a little more irritable. That would be one way of thinking about mentalizing or recognizing that we can take various perspectives on our experience and the experience of others. I would say that all psychotherapy, regardless of whether it names this or not, has as part of its effective component, not just the relational dynamic with the therapist, but whether and how it enhances the client's or the patient's perspective taking, the understanding about the ability to take a larger perspective at whatever the experience that in the moment, whatever's happening is. So in various ways in IAT, we work on enhancing metacognition. We draw a lot from Peter Fonagy and Alan Bateman's and John Allen's work on mentalizing and their work on mentalization-based therapy. We think that's really terrific. we'd like to include components of that in our model, which we feel is larger and more comprehensive for specifically resolving attachment insecurity. But, so that's a component of, again, we build upon what's out there, we respect what's in the field, and hopefully add something to it. The third pillar is really what is most unique about this model, and that's the use of embodied mental imagery to work on changing the internal working models of insecure attachment relationship. John Bowlby wrote a lot and spoke and taught a lot about internal working models, which are essentially the internal representations of attachment experience. So if I, with my caregivers, most of the time, more often than not, experience them as available, or my primary caregiver as available, as interested in me, as attuned to what my needs might be, as being delighted by who I am as a distinct and unique child, supportive of my exploration and discovery as I look more out into the world, then I'll develop an inner representation that people close to me are likely to be that way. Not everybody, but that I can reasonably expect that the world, first through the form of caregivers, but then later on, the world in its larger sense, is reasonably available to provide for my needs. So that would be the internal working model of attachment security. If I didn't develop that, didn't have those kinds of experiences with my primary caregiver or caregivers, then my internal experience would be very different. It would be that, oh, I can't really expect that somebody will be there to recognize me and be attuned to me. I can't expect that I'll be protected sufficiently. I can't expect that somebody will be delighted by just who I am. So maybe I have to perform and accomplish in order to get love, rather than just be able to be my unique, distinct self. That would be internally represented kind of through forms of memory traces and memory experience as insecure, or that would be described as an insecure internal representation. The traditional approach to psychotherapy for insecure adults is the therapist as good attachment figure model. It aims to give the client or the patient a new and positive, different experience with a significant person in his or her life, their life. And that's the therapist. The therapist aims to be a good attachment figure. Now that's helpful, and there are limitations to that. So, for example, the therapist is the internal working models are of the self as child in relation to an adult caregiver. There is a caregiving relationship in a patient and therapist dynamic, but the patient is not a child if it's an adult patient, and that's what this work is focused on. The patient is an adult, and the therapist is not the adult patient's parent. So that there can be great benefit to a positive relationship between the two and the experiences the patient has with the good therapist. But it's not likely to change the original internal working model. So what we do, and this was an innovation from Dan Brown, who drew from several others throughout years and decades before he first proposed this, is that we collaboratively engage the patient in creating, and we'd say co-creating, embodied relational imagery of the patient as a child interacting with an imagined new and different parental caregiver who is providing just the right ways of being for the needs for that particular child to develop security. So, for example, after explaining all of this approach, and the process of the mental imagery to a patient, I might say, okay, now imagine yourself coming to feel yourself more and more as a very young child. Feel yourself younger and younger, and more as a very young child, so that from the inside you feel yourself as a young child you are. And we work with that to help the person kind of imagine and really envision this. And then when the client, the patient indicates that he or she's or they're feeling the self as a young child, then I might say, now being the young child you are, imagine that you're not alone. Imagine that you're with parents, but not the parents you grew up with. Imagine you're with a new and different set of parents, parents who are ideally suited to you and your unique nature as the child you are. These parents can be any ways that you'd like them to be. So through the creative freedom of your imagination, you can play and work with this sense of their characteristics and their qualities until they feel just right for being the parents that you would most need to feel secure in your connection with them.
And sorry to interrupt, David. Just it's important to underline here that you shouldn't use your own parents, even if there were good elements to that relationship, because other associations will get brought in. Is that right?
That's correct. Yeah, that's a very good observation. Yeah, many people will ask, they'll say, well, how about if I imagine my actual parents, but a better version of them? Um, and I'll respond to that by saying, you know, we can appreciate that your actual parents did the best they could given who they are or who they were. And they have their own attachment history, their own difficulties that probably led to some of the difficulties that you experienced with them. So we're not criticizing or rejecting your actual parents, but let's see if you can create a new and different set of parents so that all aspects of them, as you experience them now in the imagery, can be different. And you won't associate with these parent figures now anything that you had as problematic in your experience with your actual parents. So that's an important point that you raise. Yeah.
Okay. Sorry, well, I interrupted. Was there anything else you wanted to say about the method, or?
So I described the creation of the imagery, first of the experience of the self as a very young child, and then of the imagined parent figures. But there's a step that comes before that. You notice, if you recall, when I first started describing this, I labeled it as embodied mental imagery or embodied imagined parent figures or embodied experience with imagined parent figures. The embodied aspect is a really important component to this model and why we think it's effective. During the first 2 years of life, when attachment representations are formed, a child operates not according to a developed cognitive system or narrative, linear, language-based system. That doesn't kind of start developing till around 3 years of age and isn't fully online and functioning till around 4 or so. So for the first 2 years of life, the processing system, let's say we could say the operating system of the child is more bodily based. It's physical, it's visceral, it's behavioral, it's about movement, it's about sensation, it's about feeling. It's the physicality. That's why hugging and physical contact is so important in a safe way, between a parent and a child. So as part of the foundation for creating new and different internal working models, the first step in this sequence of the therapy process is to help the client or the patient orient toward his or her or their physical experience, to get out of their head, right? And there's going to be thoughts there, of course, that it just continues to happen, but to try to shift the attention and the awareness to what's going on in the immediate felt sense of the body. So I might say, Well, feel yourself in the chair. Just notice, the arrangement of the arms and the legs, and take a couple of breaths. Feel the sensations where the body's in contact with the chair. Look through the body. Notice if you want to move or shift or adjust in any particular ways. Bring attention to the breath, the inhalation, the exhalation. There's many ways to do this, but the basic principle is bring attention to the body so that that becomes more the center of focus and experience as much as possible in the moment, because that creates the conditions that are more similar to what was operative during the first 2 years of life when attachment experience got internalized. If, as an adult in the therapy sessions, the client or the patient comes into that operating system, then we do the imagery, it's much more likely, we think, and we find, in terms of positive outcomes, that the internal representations will get modified towards security.
Do you think it's whenever you're doing that, whenever you're getting into this embodied state, you're almost enhancing the neuroplasticity of those attachment patterns whenever it's happening, so they're more flexible to change? Whereas if you just go cognitively, you're not really getting that.
It's another really important point, because there's some very interesting neuroscience research that has explored this whole notion of internal working models. Nobody has seen an internal working model. It's not something you can identify in, somewhere particularly in the brain. But it turns out that there are certain brain cortical structures and brain networks. The core network of the brain, it's often been termed, is considered to be relevant to the formation of internal working models. In research that various neuroscientists have done in recent years, in the last 20 years particularly, it's been found that remembering or imagining new and different experience, imagining a fictive experience, something that didn't happen, but somebody can create through their imagination, actually engages the same cortical network that is considered to be relevant for internal working model formation. So when we engage the body, we support the embodiedness of this whole process, and we support the creation of fictive experience, imagining new and different positive attachment experience with caregivers that didn't actually happen in the client or patient's life. We think that, as you referred to, that actually creates change at the level of the brain and of the whole nervous system. And there's some compelling research. There's still a lot to be done in this area, but what has been done so far is quite compelling.
That's fascinating. Can you just on the research point, can you maybe tell us about the 2017 study that was done? I think it was in Paris on PTSD and the use of, was it imagery? Is that right?
Yeah. Thanks for bringing that up. That was done by Federico Parra and Carol George, who's very well known for her work in the adult attachment picture system as an assessment tool for attachment. But the two of them and several others were involved in a study that didn't look specifically at attachment, but were interested in how the introduction and the use of the ideal parent figure imagery method might help adults with complex post-traumatic stress disorder. So the study was rather small. There were 17 adults, there were 17 women who were considered to have complex PTSD. And they were introduced to the study method. And in one session, they were guided through a standardized version of the ideal parent figure imagery. I should say here, and the authors of this study also highlighted that that we don't recommend standardization because everybody's different. And even though there's a general framework for how to create the imagery, co-creation is very important. So the therapist needs to attend to the particularities of the person in front of him or her or them, that that every imagery process, every imagery session will be different. But for the purposes of research and to try to reduce the range of variables to try to find a research effect, these researchers did do a standardized script of the ideal parent figure imagery. So they did it in one session. Then they made a tape for an audio tape of that session, and they asked the study participants to listen to that session between subsequent therapy sessions. And they had 4 therapy sessions total, where they were also given this protocol. And they listened in between a lot or a little. It wasn't calculated or wasn't assessed how many times each participant listened to the recorded tape. But what they found was that after just the 5 sessions, the initial session where it was introduced and the 4 subsequent sessions, that various symptom measures showed reduction in complex PTSD symptoms, significant reduction, and measures of quality of life experience showed insignificant increases just after those 5 sessions. At 8-month follow-up, those results persisted, that the symptomatology of the complex PTSD remained low or lesser than it was at the beginning of the study, and the quality of life scores were higher than at the beginning of the study. There were some indications that attachment benefited, the security of attachment benefited, but again, in this small study, there wasn't a specific assessment of what the attachment patterns were. So it was intriguing, it was supportive, it validated the power that this method can have in certain areas, but we do need to conduct more research in a more attachment-focused way in order to show more people, more therapists, more researchers, more the world, that this method that clinically we see is quite useful and quite effective, also it has empirical support.
That's so interesting. Do you think there's a case to be made that when someone comes to a therapist that might have experienced PTSD or developmental trauma, that there's a case to be made for maybe addressing attachment issues first, or at least concurrently along with the trauma? So that should be a primary focus of the therapy.
We find that not just we, but the research highlights that attachment insecurity is a risk factor for other types of psychological, emotional, mental health challenges and difficulties. It seems that attachment security supports resilience, so that when a child encounters the inevitable challenges that are going to come up through development, a secure child will have more inner resilience and coping mechanisms and ways to process and ways to not get more hurt by the challenges that arise. A child with insecure attachment will be less resilient, will be more vulnerable, and more vulnerable to abuse and trauma, which may be why they were insecure in the first place. So there can be a vicious cycle where problematic parenting creates insecurity. The continuation of the problematic parenting and negative or adverse childhood experiences can then have a deeper impact on the child because of the vulnerabilities. We find that when adults come to treatment, that if they have an underlying attachment insecurity, that it's most effective, it makes the therapy most effective and efficient to treat that attachment insecurity first. So, for example, I think of one client who had a post-traumatic condition based on unfortunately being impacted by a terrorist attack, and he had understandably PTSD in response to that. He was offered some of the standard PTSD treatments for that, but it made him worse. He was actually having more nightmares as a result, and more internal disorganization. And so he dropped out of that particular treatment and found his way to me. And I did an assessment because about his attachment status, because based on what he was telling me, in addition to his description of the trauma, it seemed to me that he had an anxious, preoccupied form of insecure attachment. An assessment validated my impression of that. For the first part of treatment, we didn't address the trauma at all. We addressed his attachment insecurity until he developed what's called earned security, which is the presence of the indication of an internal pattern of security in somebody who initially had been insecure. So once he was earned secure, then we started addressing the trauma. And he didn't get more overwhelmed as we were doing that. And he didn't get more disorganized. And our interpretation of that, we've seen that in many patients. Our interpretation of that is that, again, security creates inner stability. It supports the formation of inner structure so that there's more resilience against impacts, negative impacts of things that will inevitably occur. And for somebody like this client I just described, when we started addressing the trauma in a very direct way, he had the inner stability and the inner structure, so he would not get more disorganized or some kind of collapse into the inner disorganization that was happening before. And the treatment proceeded quite well. So our general recommendation is that it's, given how pervasive attachment insecurity is, you highlighted that 40% of adults, by many estimates, have insecurity. That's the general population. It's also found that within the clinical population, within the group of people who seek psychotherapy or are hospitalized for mental health problems, the prevalence is much, much higher. So as a general rule, I think, and my colleagues think, that it's really helpful as part of the initial assessment, which should be comprehensive, so the therapist can get a good understanding of who it is and what it is the person is coming to treatment for and with, whether attachment insecurity is a component of that. If it is, that's the pathway for many people as the initial approach, which will make therapy more efficient overall.
Amazing. Now, another part of your model is about enhancing people's ability to collaborate with others. Let's say I was coming to you and you identified that that was a major issue for me and something that I needed to improve. How would you go about helping me to improve my capacity to collaborate with other people?
Well, first of all, I would highlight very explicitly that therapy is a collaborative process. So I would say that, okay, the first things we're going to do an assessment so that we can understand more about you and what has contributed to some of the problems that you're coming to therapy for. We might identify, in the case that you're referring to, that the person has had difficulty in relationships, difficulty engaging in a mutual give and take in relationships. And if that's the case, I would talk to you about that. I'd say, one thing it seems to be pretty consistent through your history is that you've had these particular kinds of relational problems where it's hard for you either to let somebody offer their input to a particular task or into the relationship because you think you have the right way all the time or most of the time, or alternately, maybe with someone else, it would be you undervalue your own contribution. You look too much toward the other person for figuring things out or taking the lead because the self-esteem is not well developed. So I would say, I would say, isn't that interesting? And we would talk together about these patterns. I would say, let's explore these patterns together so that in this therapy process that we are both involved in, we can find the ways to most benefit what it is the goals are that together we can come up with for this therapy. So notice all the relational collaborative language I just used, we and let's and us and our. So that becomes woven in through the process, just in a natural way, because I see it as a collaborative process. So I'm not making up that language. I'm not, manipulating with it. It's actually how I see the relational aspect of the therapy and how valuable that is. So yeah, that's the foundational component. Then, of course, there would be other ways over the course of therapy to maybe practice collaboration, either with me in the therapy process or have some homework so the person practices being a little more collaborative in their other relationships.
Very cool. So it's almost like they're doing a test drive collaboration with you, and just the process of therapy itself, that is the collaboration, and then that can then be modeled in other areas of their life too.
Yes. And it really comes from developmental literature that highlights the collaborative aspect of a healthy, secure attachment dyad between the infant or child and the caregiver. That's fundamentally collaborative. The infant has to give signals to the caregiver. The caregiver has to pick up those signals, has to know how to respond to those signals. The child experiences those signals and will have some other expressions as a result. There's this back and forth that sometimes is called a dance, the relational dance that we hope happens because that tends to support security.
For sure, for sure. Now, something I want to ask you about before the end of the interview is about the 5 primary conditions that promote secure attachment and why these are so important for everybody to understand.
Great, thank you. Yeah. I indirectly referred to them earlier, and as I name them again, you'll remember that I made reference to these. Um, the foundation for this is Mary Ainsworth's description of what she called maternal responsiveness. So maternal responsiveness is, according to Mary Ainsworth, the category of the ways of being of the caregiver. She used maternal because that was most prominent in her era, that the mother was the primary caregiver. And probably in general, that's still the case, but fathers typically are taking a much bigger role now in caregiving. So we could say parental responsiveness, but Mary Ainsworth's term was maternal responsiveness. And through the years subsequent to her presentation of that principle and the characteristics that are included in that, many attachment researchers and clinicians have highlighted what they consider to be fundamental parental ways of being that are important for promoting security. And Dan Brown and I and others in the group, the 9 of the original 11, in addition to Dan Brown, or 9 of the additional 11 created the book, the Attachment Disturbances in Adults book, which came out in 2016. But in that book, we published the category that we termed the 5 primary conditions that promote secure attachment. And these are not only the ways of being of the parent or the caregiver. Remember, I've highlighted how important it is to see attachment as dyadic. It's a dyadic relational phenomenon between the caregiver and the infant. So in our model of the 5 primary conditions that promote secure attachment, there are parental ways of being, and there are also what the child hopefully experiences in response to the parental ways of being. So the first one is protectiveness. If the caregiver provides adequate protection against harm, can never be 100%, the child's going to trip and fall and skin the knee or get scared and cry, But in general, the caregiver is neither underprotective nor overprotective. And then hopefully the child will have an experience over time of the parent being protective to a good enough degree, so that that gets internalized as the internal message that, sometimes I get hurt or sometimes I get scared, but more often than not, my caregiver will be available to help. It's not a conscious thought necessarily, but it's an implicit memory. It's a bodily based, felt sense of being able to trust the availability of the caregiver for being protective. The second condition that promotes attachment security is the parental attunement, the degree to which the parent can tune into the child's states, inner states, and thereby be aware of the child's needs and be able to respond in a contingent way, meaning an accurate way, to what the child is actually needing in the moment. So the child is kind of irritable and is clearly needing something. The parent who tries to be attuned may be accurately attuned to what's creating that state, or may not be. So, for example, the parent might think, "Oh, he's hungry, so I'm going to feed him. I'm going to feed my infant. He must be hungry." Tries to feed the infant. The infant pushes away. No, no, no. Well, oh, okay. So the parent wasn't accurately attuned, even though the interest in being present to the child was there. But the parent notices that even though the child's not feeding, the child is calming just by being held. Aha, so what my infant needed right then was just some comforting, just being held in that moment. So the parent tries to be attuned as much as possible to the inner states of the child and tries to respond effectively effectively to whatever those needs are. If that happens to a good enough degree, say more often than not, the child will feel seen, will have the inner experience that, oh, when I have a need, somebody is interested, somebody cares, somebody can be available, can recognize me and what my needs are. That promotes security. Third is the availability for providing comfort and soothing when the child is hurt, is upset, is ill or sick in some way. So the child, of course, is going to feel, uncomfortable states. An attuned caregiver will recognize those states and will know the child well enough to know in that moment how best to offer soothing and comfort for the child. And then the child will feel, oh, okay, when I'm upset, soothing and comfort is available. Interestingly, the good enough presence of this during development is a significant factor in our development of internal emotion regulation skills. Okay, so initially, we depend on our caregivers, the world, to regulate our emotions because everything's chaotic, or not everything's wired up early on to promote emotional regulation. But if it happens to a good enough degree, more often than not, that the caregiver can provide soothing and comfort when the child is upset or hurt or scared, that gets internalized. So that over time, when the child becomes hurt or scared or upset, there'll be an internal representation of there having been comfort and soothing. And so the child becomes less dependent only on the external. When that doesn't happen to a good enough degree, the child and then the adolescent and then the adult keep looking to the outside world for comforting and soothing. For example,
that might lead to addictions then.
Addictions, alcohol, drugs, shopping, sex, internet addiction in some way. So looking to the outside because there's not enough internal regulation ability. Fourth condition is the parent being delighted by the very being of the child, not only what the child does. Okay, the child is a human being, not a human doing. It's fine for the parent to be excited and happy when the child draws a beautiful picture or gets a good grade in school. But even more important is that the child experience the parent as happy just that the child exists, and expresses that. the parent lights up when the child comes into the room. The child will experience that as, oh, I didn't do anything in particular, but I'm just here and mama's happy. That gets internalized in a way that supports security. Now, you've noticed I've been highlighting phrases to a good enough degree, more often than not. Obviously, no parent is going to be delighted every time a child comes into the room. The parent's going to be distracted, the parent's going to be annoyed sometimes, the parent, whatever. But again, if to a good enough degree, drawing from Donald Winnicott's notion of good enough parenting, this happens more often than not. The child will internalize that in a way that promotes self-esteem and inner security. The last condition is a little bit different than the first four. The first four are all about the dyad orienting toward each other. Now, all that's important, but we don't want only that to happen, because the child also needs to have experience beyond the parent. So there's the natural exploratory system that gets activated, particularly when the child is secure or feels secure that the parent is going to be there. There's a secure base that the child can go to whenever there's fear or upset or just wanting to share something positive even. But from the secure base, it's really helpful for the child to look away from the parent and find out what's across the room or find out what's, on the other side of the yard. The parent obviously wants to keep an eye on the child. That's the protectiveness aspect, but also to allow the child to explore and discover, and to give the child the experience that that's okay. And not only is that okay, that's good, because that's part of what helps self-development. The child has experience with the caregiver and also without the caregiver, going beyond the caregiver. And that's an important component of security and of self-development and of overall well-being too. So those are the 5 conditions in their context.
Well, David, it's been such a pleasure, and we've covered so much important ground during this interview. So thank you so much for sharing some of your insights and wisdom with us. I know for people that want to go deeper after this conversation and learn more about your work, you've got a really good online course. Where can people find out information about that? And could you also tell us about your book that you co-authored with Dan Brown as well?
Sure. So the course is, we're quite excited about the course. It's a multimedia, online-based, self-paced program that has text, video, audio, a lot of links to external resources that if people want to go deeper into some of the concepts that we present, they can go to. If people do everything that's in the course, it's about 100 hours total. And we consider it the level 1 foundational training for integrative attachment therapy. We have levels 2 and levels 3, which are live trainings, in-person, therapeutic, clinically focused skills development course or components, levels 2 and level 3. Level 1 has a lot of demonstration videos. It gives people the foundational theory, the foundational principles of IAT, the 3 pillars, and then a bunch of demonstration sessions so people can get a sense of how to go about this. More information about this is available at integrativeattachmenttherapy.com. Integrativeattachmenttherapy.com. This course is, of course, based on the material that's in the book that I co-authored with Dan Brown, and that others who were part of the study group made contributions to. That book was published in 2016, and although it's still very valid and very useful and a tremendous, we think, of course, a tremendous resource for the field, our IAT training has built upon that work and has brought in some new developments, both from the field since 2016 or since 2015 when we had to submit the manuscript for the book. A lot has happened within the field, so we've included that in the course. We've also made some significant modifications, even to the model itself. So in the book, people who are familiar with it or who may get it and read it will see that in the book, the three pillars have a reversed order. That the first pillar is the embodied mental imagery, the ideal parent figure process. Second is metacognitive development, and the third is collaborative development. We said, well, there were reasons that Dan and we at the time decided to put it in that order, but subsequently we've decided to turn it on its head, which, as I highlighted earlier, is informed in part by the foundational element of the collaborative relational component to all psychotherapy. So we wanted IAT to have that as its foundation as well. So that is paid attention to, and that's developed further even before we go into the ideal parent figure imagery. I should say just very briefly that there are many people, some therapists and some people who aren't even trained as therapists, who are offering ideal parent figure coaching or ideal parent figure facilitation for people. We have concerns about this because IPF should be a therapeutic process and it should be practiced by people who are trained in therapy. Some of these people who say are not trained in therapy are going to be helpful to some people who come to them and get facilitated for the ideal parent figure imagery. But I have had many people come to me who have worked with, say, non-therapists and people who aren't fully trained in this approach, who've had bad experiences because maybe they started dissociating during, the more severely insecure, or the people with more severe insecure patterns because of, say, trauma histories or whatever else may have contributed to that, are more likely to be vulnerable to a whole host of things that a trained therapist can understand how to respond to. But someone who's not trained therapeutically is not as likely to know how to respond. So I've been working with many people, too many people who've had bad experiences with the non-trained people. So that's just a little let the client beware notification on that.
It's important to say. And the website is integrativeattachmenttherapy.com. Is that right?
Correct. Yes. Yes.
Okay, David, thank you so much. It's been such a pleasure. And I want to wish you the best with your work going forward.
Niall, thank you so much. I appreciated your questions, very sophisticated, and happy to have the opportunity to talk about this work. So thank you.